Okay. Hello, I'm Dr. Petra Steinbushel, Director of the UCSF Child and Adolescent Psychiatry Portal, and I am delighted and honored to introduce Dr. Alicia Lieberman. Dr. Lieberman is the Irving B. Harris Endowed Chair in Infant Mental Health and Vice Chair for Faculty Development at the UCSF Department of Psychiatry. She is also the Director of the Child Trauma Research Program, and she is the Director of the Early Trauma Treatment Network, a collaborative of 4 university sites that include UCSF, San Francisco General Hospital, Child Trauma Research Program, Boston Medical Center, Louisiana State University, and Tulane University. She has been grounded in early childhood attachment from the very beginning of her career, where she trained with Mary Ainsworth and Selma Freiberg. And she is going to teach us today about how children heal from trauma.
Thank you, Petra. It's a privilege to be here. Thank you for inviting me, and thank you for your leadership. I'd like to start by lingering on the title, How Children Heal from Trauma, and applying trauma-informed principles. And I think I'd like to highlight 2 main principles for how children heal from trauma. One is providing at least one actively protective relationship, what Petra described as attachment, a secure attachment, with a caregiver that helps the child feel safe, loved, cherished. And 2, helping the child, even very young children, name the trauma and learn that it was not his or her fault that it happened. Those 2 core principles can be used in any system of care: pediatrics, childcare, mental health, child protective services. And we hope to create a therapeutic community where we don't need to be a therapist to be therapeutic, and where every member of a child serving system can help children and their families heal from trauma. The learning objectives for today are to describe ACEs, traumatic stress, and toxic stress physiological impact at the different levels of the organism: biology, cognition, and social emotional functioning, referring to tools and interventions that promote well-being and resilience, and describe briefly how to work with multidisciplinary teams to achieve our goals. There is a great deal of interchanging use of words like adversity and trauma. And I'd like to talk about what each term means, because adversity and trauma, although often used interchangeably, have specific meanings. Adversities, according to the Merriam-Webster dictionary, refers to conditions of serious and continued difficulty or misfortune, as the dictionary calls them. And in the list of ACEs, for example, a parent who uses substances, or a parent who is in prison, or has a severe mental illness, would be an example of a child living with an adverse condition. Trauma is a specific form of adversity, and it involves events that actively threaten survival or physical and emotional integrity. In the ACEs list, for example, physical abuse, sexual abuse, domestic violence. Now, traumas often happen in the context of a larger set of adversities. For example, domestic violence and child abuse are more likely to happen when a parent is intoxicated or when the parent has a severe and untreated mental condition, such as, for example, paranoia which affects the parent's ability to understand what is safe and what is dangerous and might attribute danger to situations that are objectively safe. So in the definition of trauma, we highlight threat to survival or physical and emotional adversity and, integrity, often in the context of general adversity, but not necessarily so. The toxic stress response is an overarching term that became popularized to describe how, at the biological level, we respond to chronic and severe adversity and trauma, particularly in the absence of protection. And we will describe some of the specific manifestations of a toxic stress response later on. But I would like to also frame the toxic stress response in the context of normal, expectable development, and remind ourselves that the expectable normative anxieties that we all have throughout our lifetime begin in the first 5 years of life. These are the fear of being abandoned, the fear of not being loved, the fear of being hurt, and the fear of being bad, or what Freud referred to as the fear that we are going to be condemned by ourselves or by society for not living up to moral and social expectations that are basic to belonging. Now, the fear of separation starts in about 6 to 8 months, and it's essentially the baby's way of saying, why would you leave me if the most important thing in the world is to be together? The fear of separation can be understood as the price that we pay for being able to love, and the capacity for love becomes crystallized in attachments when the baby is about 6 to 8 months of age. The fear of losing love happens between 18 and 36 months, starts emerging at that age. And I'll give you an example of a 4-year-old who said to his father, "Do you love me when you are mad at me?" Which gives us an example of how existential this question is. And the father answered, "Of course, I always love you, but there are times that I get mad at you when you don't do what I want, but I don't like being mad at you." And the 4-year-old responded, "Well, I don't like it when you ask me things that I don't want to do, and I don't like it when you get mad at me." And he went off to play. And this exchange shows both partners' capacity to speak openly about what they liked and what they didn't like, and to reaffirm that their love continued to exist even among the ups and downs of emotional reaction in the moment. Fear of body damage emerges when babies begin to move autonomously. And for example, when they begin to crawl or they begin to walk, and they start getting hurt more often as a result of that. And we have wonderful rituals like kissing the boo-boo that reassure the child that the parent or the caregiver is there to protect them and to restore the sense of physical integrity. The fear of being bad, which is the earliest origin of a moral conscience, starts in the preschool years. And one example that I think is very compelling is of a little 4-year-old again, who was having a cognitive test and was being asked about the names of vegetables. And he was going along very happily answering all the questions until there was a question about a vegetable that he did not know. And he stopped for a moment, and then he slapped himself. And then he slapped himself again, and then again and again. And the assessor asked, "Why are you slapping yourself?" And he said, "Because I'm bad." His not knowing for him was equivalent to there being something deeply wrong with him. And it's worth noting that this little boy was often slapped as a way of disciplining him. So he had internalized a sense that there was something wrong with him. And the assessor said, "You are not bad. Most 4-year-olds don't know the name of this vegetable." And the child looked at her with some mistrust. And the assessor again said, "I promise you, most 4-year-olds, my own son doesn't know the name of this vegetable." And the child visibly relaxed. This is an example of how moments of everyday life can offer an opportunity for repair, for assuring children that certain convictions that they hold, which might be quite self-destructive, are actually not correct. And when we talk about a secure attachment, about protective relationship, we are talking about relationships that enable the child to repair a breakdown in the sense of connection with an adult. Now, reality matters, even though these anxieties are normative and they emerge regardless of how much a child is loved and protected, regardless of how well the family is functioning. The fear of separation, the fear of losing love, the fear of being hurt, and the fear of being bad are unavoidable fears. It's part of being human. But when the reality is chaotic, is violent, is frightening, then those events that happen in the actual surrounding of the child confirm that those anxieties are real. And unfortunately, the first 3 to 5 years of life are the most dangerous in the child's life. It is when mortality as the result of either accidental injury or child abuse or interpersonal violence is highest. And in that context, we can see that fear is an adaptive survival response. It is what the organism has taught us to do to protect ourselves. And the 3 most basic survival responses are freezing in place, fighting back, or fleeing. And what we see as the child develops is that what becomes an external behavior can become internalized in the form, for example, of freezing internally by dissociating from a particular situation, pretending that we don't see it, by becoming aggressive and fighting back before we are hurt ourselves, or by avoiding situations that are perceived as dangerous. And many times, for instance, school refusal is a way of avoiding separation from the parents, or avoiding the classroom because the classroom is perceived as a place where the child is being bullied. And those are reasons that when a child is showing a symptom, we want to know what is the meaning of the behavior. How can we understand the behavior so that we can help them cope with it in a protective fashion? Now, what are the effects of early childhood toxic stress? When dangerous situations heighten a child's self-protective response, hyper-alertness, avoidance, freezing in place, aggression, there is a cascade of reactions at the biological level, the cognitive level, and at the social emotional level. And the heightened release of stress hormones at a chronic level has toxic effects on brain structure and physiology, hormonal regulation, the size and reactivity of the limbic system, for example, the amygdala, the extent, the size of the hippocampus, and there are social emotional effects and cognitive effects. One example that I'd like to give you from my own experience working with very traumatized children and their families is that when we assess them for cognitive performance, we find that when they are referred for treatment, they are often 10 to 15 IQ points lower than the norm. When we test them again at the end of treatment, after they've learned that the trauma is not their fault, and after we've been able to help the parents or caregivers create a safe environment for them, the IQ very often goes back either to normal or to superior. And what we've seen in implementing these cognitive assessments is that very often there is a hyperarousal or a withdrawal, like that little boy I told you about who hit himself in response to not knowing. When there is a trigger in the test, for example, a child who was asked, "What's a knife used for?" who became totally dysregulated because he had seen a knife used to hurt somebody he loved. Then, of course, the test gets derailed. And when we're able to put a knife in the context of what it should be used for, and how sometimes it was used to hurt people, and that should not happen. It is wrong that it happened. And we are working to make sure that it doesn't happen again. Then the child is able to be desensitized to that traumatic trigger and respond with a normative answer to the question. So it is really important to think, when we think about the effects of early childhood toxic stress, to think simultaneously about acknowledging the effects that it can have, for example, in this slide, immunologic, inflammatory level, endocrine, metabolic level, but also to think of the plasticity of the organism, of the brain as an organism that adapts to circumstances, and that as we create nourishing, nurturing, protective circumstances, it adapts to those circumstances, and that there are phenomena such as thriving in the wake of adversity or traumatic events that are called resilience or post-trauma growth, and that we should simultaneously hold the effort to prevent toxic stress, the effort to address toxic stress, and the hope that development will be restored in a healthy trajectory when we create the conditions for that to happen. Now, there are changes in the parent-child relationship that happen in the context of chronic stress. And one of the reasons that this happens is that the child has a parent who is also traumatized. This can be because young children and parents are often together, so that, for example, a car accident affects both of them, or the parent witnesses the child's accidental injury in a way that shakes the parent to the core. Most of the time, parents remain protective, and children use their basic trust in the parent to restore feelings of safety. For example, a 3-year-old girl who nearly drowned and became unconscious after falling into the swimming pool during her birthday party. She asked when she became conscious again, "What is my cake?" And we can imagine her reliving her loving family celebration of her while she was working her way back to consciousness. Another child, a 4-year-old, said to his father, "Not all dogs bite." When the father lovingly tried to move his son away from an approaching dog a couple of weeks after the child had been bitten by a dog that he tried to pet in the park. However, in more frightening or less supportive conditions, the traumatic event can trigger negative changes in the child-parent relationship. A 1-year-old girl that I will call Elsa persistently turned her face away and refused to be held by her mother after a stranger had attacked them on the street. And at that time, the stroller containing Elsa was overturned, the mother was injured in the face, and the child and the mother were separated when the mother was taken to the emergency room and the child was taken to the police station for several hours while the mother received medical care. And as we look for the meaning of the child's avoiding the mother, we can imagine that she's thinking, "You left me. You scared me. Who are you? You don't look the same. Will you leave me again? Will you frighten me again?" And the mother, in turn, was deeply hurt because she thought that the child was rejecting her. And this compounded her sense of having been damaged in the face and worried that she would not heal. The mom talked about this to the childcare provider, and she said, I worry that she'll never love me again. And here you see how the early fear of losing love can come back in the context of an adult circumstance that triggers it. And this wise teacher said, No, Elsa is worried when she sees that your face is hurt. You look different to her. She doesn't know that your face will heal. It makes her remember how scared she was when you were attacked and you went away and you didn't know that she didn't know that you would come back. And this conversation helped the mother put herself in Elsa's shoes and realized that Elsa's avoiding her was a manifestation of this little girl's confusion about what is happening her. And what the teacher and the mother started doing together at the teacher's initiative was starting a game where they used toys to reenact the attack. And they made a red mark with crayon on the mother doll's cheek to show the injury. And then they erased it again and again. And the child started joining in this game with great glee and started turning to the mother again. And this was a way of repairing the breakdown so that the mother and the child no longer were only reminders to each other of this traumatic event, but they could reconnect with their attachment that they had been creating together until the attack had happened. They repaired their relationship. We often see children responding with affect and behavioral dysregulation in many settings, in the doctor's office, in the childcare situation, on the street, in many circumstances, and very often we respond by giving them Ritalin or diagnosing them with ADHD. And I would like to suggest that before a diagnosis, we need to ask, what happened? What could account for this child's dysregulation, for the hyper alertness, hyperactivity? And often what we find is that trauma responses mimic ADHD responses. And of course, because toxic stress responses and trauma stress responses affect the entire body, there might be an overlap between traumatic stress responses and ADHD, but we also do know that behavioral interventions are very effective in reducing these dysregulated kinds of behaviors, as the example of Elsa suggests. This slide gives us a glimpse of the continuum of stress, the spectrum. And some people call it positive, tolerable, and toxic. Other people called it expectable, costly, traumatic. Different words are used in different contexts. But what is common to all the language that is used, positive, tolerable, toxic, is that we all experience a continuum of stress in our lives. And we often feel aroused in response to that stress. And positive stresses are normative and expectable challenges, like the birth of a sibling for a young child, or balancing one's budget, or calibrating one's intimate partner relationship for an adult. And there are more costly stresses like medical conditions, serious and persistent financial insecurity, chronic family conflict. And then toxic stress can move from tolerable to traumatic when an event happens suddenly and unpredictably, does not give us time to mobilize coping resources, or when it happens again and again and again in an unpredictable manner. In the case, for example, of unpredictable domestic violence or living in a chronically dangerous neighborhood. What qualifies toxic and traumatic is a terrifying helplessness when we are flooded by intense stimuli that signal dangers that are too big and immediate to overcome. And in the aftermath of these events, we can no longer take safety for granted. And it has been said that accurate reality testing is the first casualty of exposure to severe, unexpected trauma or an adverse event, because even moderate, unexpected stress can trigger a reminder of the event. And everyday stimuli are no longer neutral. The classic example is returning veterans, for example, hearing a car engine that misfires as a reminder of actual fire from firearms being discharged and responding with a panic attack. So when we talk to our patients, I think it's very helpful to help them differentiate between what are their adaptive coping responses and when they might be responding to reminders of difficult circumstances in ways that are not helpful in the moment, and help them think about what helps them and who helps them when they are experiencing stress that is difficult to modulate and manage. And this brings us to the question of COVID, because by now, after so many months of fear, isolation, and the negative effects, we know that COVID is a classic example of how reality confirms and reawakens our earliest anxieties, most particularly in this case, the fear of body damage and the fear of loss of loved ones, and fear of the unknown. What will happen? What will happen if? What we are seeing also is the many levels at which COVID is affecting us, both in terms of a breakdown of the social contract, lack of agreement about what is safe and what is dangerous, and turning against each other when we have different answers to the question of what is safe and what is dangerous, the pro-vaccine, the urge to be vaccinated versus the fear of the vaccine that is often expressed in aggression towards the fear of being compelled to have the vaccine. The social contract is also breaking in the context of the heightened inequities. It has been said that we're all in the same storm, but we don't all have the same boats. Some of us are in transatlantic super boats, and others are in very rickety little crafts that are unequal to the storm, and low-income people and minorities are disproportionately affected, both in their sense of financial security, faith that things will get better, and in terms of their not being able to avoid exposure to the virus. And the stressors of sheltering in place also change depending on what are the circumstances of one's home environment, how much room, how much open space, how much access to the outside, schooling, isolation, how many safety valves do we have? And I think that our patients are often so overwhelmed by the multiplicity of stressors that they are showing it both in their bodies and in their emotions, but they might not be aware of the connection between the stressors that they are experiencing and how their bodies and their minds are responding to these stressors. And as health providers, I think we have a very benevolent role to play in helping them become aware of how their responses are understandable, expectable, functional in the context of the conditions that they are facing. That in turn puts healthcare providers in new roles. And one thing that we have been finding is that telehealth can be used in a very productive way to foster a healing space, a therapeutic space, where the provider can show interest first and foremost in the immediate safety, the immediate conditions that our patients are showing, and validating feelings as legitimate responses to help them move from dysregulated to adaptive and manageable. And for young children, we find that books and storytelling and helping physical movement help to assuage and channel unmodulated stress. One example of how useful it is to keep the meaning of behavior in mind is one of a little 3-year-old who was with his mother and father in the home and was not going to preschool. The mother was working from home. The father was working from home. Everybody was quite stressed. And this child started saying, lying on the floor, rigid, and saying, "I'm dead, I'm dead, I'm dead." And the mother became very stressed by this behavior. The father laughed it off as a silly behavior, but the mother became very stressed by this response, which triggered in her the fear that this could really happen. And in a particular encounter with the pediatrician, the mother was talking about this as something that was driving her crazy. And the pediatrician said, "Have you talked to him about COVID?" And the mother said, "He's too little to know." The pediatrician said, "He overhears you talking about it, and he is with you when you watch TV. And children are like little sponges. They absorb everything that is around them. And he's trying to make sense of what's happening because 3.5-year-olds start trying to understand, what does dying mean? And the pediatrician turned to the child and said, are you worried that this big bug that's going around will kill you? And the child said, I am concerned. It's quite an amazing use of a word concern for a 3-year-old. And the mother realized the impact of that, and they started talking about all the things that they were doing to keep safe. That's why they were not going to preschool. That's why they were washing their hands. That's why they were using masks. And the child's behavior, the undead game, declined in a couple of weeks. So here again, we have the connection, naming the trauma, naming the connection with the response as a way of reassuring and restoring safety. And this is what leads us to the idea of a conceptual triad, a way of asking about adversity and making a connection between adversity and the potential link with health conditions associated with ACEs, and then bringing up the strengths in the family, the strengths in the child, the strengths in the relationship as a protective factor. One example is of an 8-month-old with recurrent ear infections and failure to gain weight. And the pediatrician realized, of course, that children are very responsive to the caregiving that they receive. And this pediatrician asked the mother, what's it like to be a new mom? And the mom said, he doesn't let me sleep. So I'm exhausted. And this opened the door to, how do you put him to sleep? Is it at the same time every night? Do you have a ritual of singing a song, patting him, etc.? And this in turn helped the mother think more clearly about this was not something that the child was doing to her. This was something that the child himself could not do for himself. She thought that he should be able to put himself to sleep by himself. And this in turn made her realize her important role as providing predictability for the child. So in this conceptual triad, what we are trying to convey is how screening for ACEs can become a door to understanding how it might be affecting the presenting condition and how we can harness the sources of strength and protection to interrupt that connection and restore a healthy trajectory. So we're talking here about attachment, about creating a secure base, about validating and normalizing fear, about cultivating a sense of perspective and being with the parent, being with the child to create solutions to the presenting problems. And in that sense, we enlist the parents' normative functions, protection from danger, caregiving, socialization, talking about what reality means, and giving the child a sense that life is valuable and meaningful, and doing this in the context of trying to understand the cultural values that the parents bring, and remembering that all of these functions can break down when one doesn't get protection in the face of stress and trauma, and becoming ourselves a source of protection. And of course, all of us who work with children remember the wonder of childhood, the joy of discovery, the joy of discovering the world, the joy of discovering ourselves, and of reveling in the love for each other. This I said about before, the question of what is the meaning that we give to behavior. Can be developmental, can be from the perspective of who is this child, the perspective of what does the environment bring. And these are the stress busters that we all rely on, that go from sleep and nutrition to being in nature, to relying on each other, to seeking mental health consultation and help, when all the more normative ways of addressing stress are not sufficient to bring a healthy trajectory back. And I can't tell you how useful children's books can be, telling stories can be, in mitigating toxic stress, both for the children and for the parents. I think that reading stories, telling stories to children as a way of being together, as a way for the parents and the adults to remember to go back to a place of safety in their own minds that gets transmitted to the child, can be a wonderful healing experience for everybody. And the wonderful program Reach Out and Read is an example of the healing power of stories. And I just want to go very quickly through one example that was created by Chandra Ghosh-Ipen in our own program, the Child Trauma Research Program. She has a series called the Trinka and Sam Story Series, where Chandra wrote books about two little mice, Trinka and Sam, who encountered a rainy, windy day, an earthquake, a tornado, a fire, and now the big virus. There are now many more than 300,000 copies disseminated worldwide in a lot of languages. They're all available in Spanish as well and in other languages. They can all be downloaded for free from nctsn.org and Chandra's own production, Piplo Productions. And in Trinka and Sam Fighting the Big Virus, which has been written in collaboration with the National Child Traumatic Stress Network, they talk about the different types of stress that families are experiencing, from needing food to missing people to worries about illness or worries about money. It opens doors about talking, putting words to family stress and conflict in school, between parents and children, parents having to work and pay attention to the children at the same time, not being able to do what we like to do, parents having arguments with each other, to basic regulations, sleeping well, eating well, routines, hugs, talking and learning about feelings, to positive interactions. How do we get connected? How do we play with each other? How do we help others? How do we come together as a community? And what we can do when nothing else works. Getting some time alone to refuel, making a plan to decrease conflict, learning what to do when we have difficult feelings. This is why stories are so helpful. Thinking when to watch TV and when to turn it off. And always keeping in mind the importance of repair, so that we can always make up after a fight and give the message We will not leave each other. We will continue to love each other. Hurt will get better, and we're basically good people in spite of our foibles. And as healthcare providers, I think we first and foremost need to take care of ourselves. The collective chronic danger increases the risk of vicarious trauma, and healthcare providers are at the forefront of it. It's essential, science-based, to take small breaks to prevent the accumulation of stress. And there's a lot of evidence that even 60 to 90 seconds repeated throughout the day can help to look outside the window, look at a tree, go around and take a little walk even within our office, remember a song that we like, say a little prayer, look at a photograph that gives us pleasure. Going inwards, looking at our dysregulated feeling, letting ourselves feel it and giving a name to it, because naming dysregulated feeling helps to reduce it, and engaging in a self-care activity that engages our kindness. I was told by somebody recently, compassion that doesn't include ourselves is not complete. And I am so grateful for being told that, because often we bring compassion outwards, but not inwards. And self-compassion completes our capacity to be compassionate. And I want to thank you for attending this presentation, and I wish you all the best in doing the sacred work that you do as healthcare providers. Thank you very much.
Thank you so much, Dr. Lieberman, and I want to express my deep gratitude for your clear and elegant teaching with so many rich and storied examples of trauma and healing. The healing power of relationship and relational repairs gives so much hope, especially in the here and now, while we're all collectively navigating our current extraordinary times and our own stress response. Thank you so much.
Thank you very much for having me, and all my best to you as well. Thank you.